Hi everyone. Good morning Vijay Kumar. Yes. So please let me know if I am audible, visible both. Yes. So let's begin. Today is our class on the must knows in FMGE. So we'll be discussing maybe one or two topics that will definitely be there in some fashion in the FMGE examination. Okay. So before that, I would like to tell you that with Unacademy now you have bigger savings where you can have 25% off on all the Unacademy subscriptions. So with the Target NEXT subscription, you can get it at an offer price of 14,344. The duration is 6 months, and for the FMGE rapid revision, the duration is 2 months and the offer price is 4,500. Okay, this price is valid only till tomorrow, that is June 30. And when do you subscribe for it, please use the code mentor. MENTOR is the code which you need to use to subscribe to this particular subscription. Going on to NEET PG Vitals. Now what is this NEET PG Vitals? Basically they are recorded videos which are available for comprehensive NEET preparation. So here you have 800 plus hours of comprehensive recorded classes for all the 19 subjects. There is exclusive content which is curated by expert faculties of NEET PG. It comprises of clinical based questions, PYQs and IBQs, and you can master your conceptual understanding and ensure excellent retention with graphs, flowcharts and high yield images. So definitely do subscribe now to NEET PG Vitals, and when you do, please use the code MENTOR, MENTOR. Also for the NEXT 23 and 24, there is access to the batch at only 6,000 rupees. You can subscribe to this by using the code MENTOR. Okay. For the FMGE students, there is FMGE Final Frontier batch, which is specifically for FMGE July 2023 students. So this is a batch which is going to last for 1.5 months, that is 1.5 months. There will be 100 plus hours of discussions. There will be live mentorship, there will be doubt clearing, and 100 plus hours of recorded content is available for all the 19 subjects for FMGE. You can get your subscription considerably subsidized rate at subsidized rate as 2,000 rupees maximum. Okay, this is a limited period offer, so please do avail it. And when you do, please use the code MENTOR. MENTOR is the code. So with that, we begin with our topic. So let's begin with the first question for the day. I would want all of you to actively participate. Okay, the first question is, in which of the following Kidnerization phenomenon is not seen? The question is, in which of the following Kidnerization phenomenon is not seen? Lichen planus, lichen sclerosis, erythema multiforme, or lichen simplex chronicus? Anyone? Anyone would want to come up with the answer? Yogesh, Vijay Kumar, Med Psycho, anyone? They've asked you in which of these Kidnerization phenomenon is not seen. Okay, so the correct answer here is lichen simplex chronicus. Okay, lichen simplex chronicus does not demonstrate the Kidnerization phenomenon. So basically, what is Kidnerization phenomenon? Kidnerization phenomenon is the development of lesions at the sites of previous trauma on normal skin, right? So basically that kind of trauma can be mechanical trauma, chemical trauma, thermal trauma, it can be anything, but then the lesions, they develop on the normal skin at the site of the trauma. Now there are conditions which exhibit true kidnerization. True kidnerization is seen in psoriasis, lichen planus and vitiligo. Rare causes of Kidners includes diarrheas, Hailey-Hailey disease, erythema multiforme, Kaposi's sarcoma, lichen nitidus and lichen sclerosis. False Kidnerization is basically because of inoculation. Okay, so there is auto-inoculation of that particular organism at the site of trauma, giving rise to the appearance of the lesions. Right? So false Kidnerization is seen in conditions where you have transmissible entities like verruca and molluscum contagiosum. It is also called as pseudo-Kidnerization. Right? Then reverse Kidner. Reverse Kidner means that when you traumatize a particular area, the lesion will clear out from that area. Okay, so psoriasis is an example of reverse Kidnerization. Some patients of psoriasis, they show reverse Kidnerization. Then there is something that is called as remote reverse Kidnerization. So vitiligo, granuloma annulare, they show remote reverse Kidnerization. It means that when one lesion is traumatized, the other distant lesions also show reduction. Okay, as MedPsycho correctly mentions, it is also called as the isomorphic response of Kidner. Isomorphic response means at the site of trauma, the same morphology as what is there in the other areas, it will be seen. Correct? So that is isomorphic phenomenon. So what is this? You can see this is a patient having multiple erythematous scaly plaques, and these are, when you examine the patient carefully, you will be able to see that they are occurring in a line like this. Yeah, you can see this. Here also they are occurring in a line. So possibly what is happening is that the patient has been scratching. Yes, MedPsycho, it is psoriasis. So psoriasis exhibits true Kidnerization. Correct? Now here you can see that the patient is wearing a belt, right? The belt is tight, it causes pressure at that site, and at the site of pressure the patient has developed linear eruption of psoriasis. Right? So Kidner phenomenon is linear trauma causing the lesions due to increase in the line of trauma, and this is seen in up to 25% of patients with psoriasis. Okay, now let's go on to the next question. You have a 3-year-old child. Okay, this child has high fever. Okay, and along with the high fever, he has perioral erosions and scaling. There are a few flaccid blisters on the neck fold and on the upper back. He also has a furuncle with pus a few days back. There are no mucosal lesions. The Nicoles Key sign is positive. What is your diagnosis? So MedPsycho says it's B. Anyone else would want to contribute? 3-year-old child, high fever, perioral erosions, scaling, flaccid blisters, furuncle on a few days back, no mucosal lesions, Nicoles Key sign positive. These are the clues that are provided. Anyone would want to contribute? Yogesh, yes, Yogesh says it's B. Anyone else? Pankaj Mishra, yes, Pankaj Mishra, you are right. The correct answer here is C. Now why is it C? So what exactly happened in this patient? Yes, Prathamesh, you are also right. The patient had a furuncle, right? So that is a staphylococcal infection. Now this Staphylococcus aureus causing the furuncle caused the release of a toxin. This toxin was called as the epidermolytic toxin. Now this epidermolytic toxin caused the cleavage of the desmoglein 1, which is present at the just below the stratum corneum. Now because there is damage to the desmoglein, there is complete damage to the desmosome, as a result of which the cells cannot remain attached to each other. So there is separation of the cells from each other, which gives rise to acantholysis. So there is primary acantholysis and you tend to get blisters. Also, because desmoglein 1 is absent in the mucosae, you do not have erosions in the mouth or in the mucosae. Nicoles Key sign is expected to be positive in any intraepidermal blistering condition, and hence the most appropriate answer here is Staphylococcal scarlet skin syndrome, because it will be seen more in the pediatric age group. It will be associated with fever. It will be associated with some focus of bacterial infection on the skin or elsewhere, like in this case there was a furuncle. There was no mucosal involvement and there were flaccid bullae. Now flaccid bullae is suggesting that there is intraepidermal cleft, and the Nicoles Key was positive. Now sorry, okay, MedPsycho and MedPsycho and Yogesh. Now just let me clarify, why is it not pemphigus vulgaris? Why is it not pemphigus foliaceus? Now see, in both pemphigus foliaceus and in pemphigus vulgaris, you have damage to the desmogleins, right? But it is an autoimmune damage which occurs to the desmogleins, because there are IgG antibodies that are formed against desmoglein 1 and 3 in pemphigus vulgaris, and there are IgG antibodies which are formed against desmoglein 1 in pemphigus foliaceus. The difference is that pemphigus vulgaris is going to show you lesions which are extremely painful which present as blisters or bullae, flaccid bullae on the skin, as well as there will be mucosal lesions. While in pemphigus foliaceus, the mucosal involvement is generally absent because desmoglein 1 is absent in the mucosae, right? But the high fever is not explained by pemphigus foliaceus, okay? And there is no explanation why the child should have a furuncle with pus a few days back, and this should be mentioned in the MCQ, right? So it is not pemphigus foliaceus, it is not pemphigus vulgaris, it is not toxic epidermal necrolysis, because toxic epidermal necrolysis is going to involve the mucosae. Here they have specifically mentioned that there is no mucosal lesion, so again that's out. In toxic epidermal necrolysis also you are going to have a history of some drug which can be the inciting factor for the toxic epidermal necrolysis, which is not mentioned, right? So the correct answer here is Staphylococcal scarlet skin syndrome. Now what is the Nicoles Key sign? Now Nicoles Key sign is the lateral pressure on the normal skin around the blister. Now when you do this, it results in separation of the layers of the epidermis, and the epidermis moves under the finger and shears off. This particular sign is positive only in intraepidermal blistering disorder, so it is very, very important for you that you remember all the conditions in which you have the Nicoles Key sign positive. Remember, Nicoles Key sign is positive in pemphigus, Staphylococcal scarlet skin syndrome, toxic epidermal necrolysis, and Haley disease. Okay. In pemphigus you have IgG antibodies which are formed against desmoglein 1 and 3. In Staphylococcal scarlet skin syndrome you have the epidermolytic toxin which targets the desmoglein 1. In toxic epidermal necrolysis there is the drug which acts as an antigen, and there is a fast ligand interaction which causes the apoptosis of the keratinocytes, giving rise to the presence of the blistering. In Haley disease, remember it's an inheritable condition in which the problem is at the level of the calcium ATPase pump. So because of the problem with this pump, the calcium from the extracellular location is not transmitted intracellularly, as a result of which there is problem with the functioning of the desmogleins, as a result of which there is acantholysis. For all these conditions, that is pemphigus and Staphylococcus aureus and Haley disease, they are going to show primary acantholysis because the damage is at the level of the desmogleins, which is responsible for keeping the keratinocytes together. In toxic epidermal necrolysis, there is no acantholysis, but you will see there is apoptosis of the keratinocytes, there is necrosis of the keratinocytes, as a result of which the keratinocytes cannot keep attached to each other. The term Nicoles Key Phenomenon, so this was the Nicoles Key sign, but the term Nicoles Key Phenomenon is applied when the superficial layer of the epidermis is felt to move over the deeper layer. Okay, it is felt to move over the deeper layer means like suppose if you have a boiled potato, and if you kind of peel out the skin, you just place your finger over the skin, you will feel it moving, right, over the underlying potato, right? So that is the kind of the feeling that you get. So the term Nikolski phenomenon is applied when the superficial layer of the epidermis is felt to move over the deeper layer, and instead of immediately forming the erosion as in the Nicoles Key sign, a blister develops after some time. So this phenomenon is seen in vesicular bullous disorders that show a positive Nicoles Key sign, like in pemphigus vulgaris. What is the significance of this phenomenon? The significance of the Nicoles Key phenomenon is that it indicates a lower disease activity in pemphigus vulgaris than those who have a positive Nicoles Key sign. So if you see just the Nicoles Key phenomenon and not the Nicoles Key sign, it is suggestive that you have a lower disease activity. Right? Now, what is Staphylococcal scarlet skin syndrome? It is a superficial blistering disease in neonates and young children less than 5 years of age. Now, why less than 5 years of age? The reason being that in less than 5 years of age, the kidney is not efficient enough to remove the toxin out of the body. So sometimes there is accumulation of the toxin, there is hematogenous spread of the toxin which is released by the Staphylococcus aureus, and that causes widespread acantholysis, giving rise to the presence of blistering. So basically what happens in Staphylococcal scarlet skin syndrome is that there is a focus of staphylococcal infection. So that could be a furuncle, it could be otitis media. It releases this epidermolytic toxin, and now this epidermolytic toxin, it spreads hematogenously, and that gives rise to fever. And then there is widespread acantholysis, giving rise to blisters. Also there is perioral scaling, crusting and superficial erosions. So this perioral scaling and crusting, please remember that is very, very important for a diagnosis of Staphylococcal scarlet skin syndrome. Perioral crusting and scaling is very common. Absence of mucosal involvement should also give rise to the clue that it is Staphylococcal scarlet skin syndrome. Staphylococcal scarlet skin syndrome is also called as Ritter's disease. Now, this is how the blisters, the rupture, giving rise to widespread sheet-like separation of the skin, and histopathology is similar to bullous impetigo. Now this is a very, very important table. So how to differentiate between Staphylococcal scarlet skin syndrome, pemphigus vulgaris and SGS10 on the basis of an MCQ. Now first remember that Staphylococcal scarlet skin syndrome will occur more in the infants or children, while pemphigus vulgaris will occur more in the adults. Toxic epidermal necrolysis in SJS will occur more in adults. Mucosal involvement will not be seen in Staphylococcal scarlet skin syndrome. It will be seen in pemphigus vulgaris and in toxic epidermal necrolysis. Nicoles Key sign is present in all the three. Okay, and the pseudo Nicoles Key sign is present in 10. Targetoid lesions. What are targetoid lesions? You know that erythema multiforme exhibits the target lesions. Targetoid lesions are where you do not have the three zones of the target. The middle pale ring of edema is missing, so you just have two zones, that is the central dusky erythema, and then you have a peripheral erythematous flare. So two zones are seen in targetoid lesions of toxic epidermal necrolysis. Perioral scaling and crusting, as I mentioned, is more common in Staphylococcal scarlet skin syndrome. While hemorrhagic crusting of lips is something that you see in SJS10. On histopathology of Staphylococcal scarlet skin syndrome, you will see acantholytic cells with a subcorneal blister, while in pemphigus vulgaris you will see a suprabasal blister. In toxic epidermal necrolysis, you will see necrotic keratinocytes with an intrabasal or a subepidermal blister. Now let's go to the next question. Pathology test is positive in. Anyone can give me the answer here? So Yogesh says it's D. MedPsycho says it's D. Yes. Both of you are right, Yogesh and MedPsycho. The correct answer here is Behçet syndrome. Cute buddies, yes, you are right. It is Behçet syndrome. Yes, Chandani, you are also right. It is Behçet syndrome. So, what is Pathology Phenomenon? So, if you have a heavy neutrophilic infiltrate or a pustular reaction that develops at the site of non-specific trauma, that is called as the Pathology Phenomenon. Okay. So, heavy neutrophilic infiltrates or pustular reaction that develops at the site of non-specific trauma, it is called as Pathology Phenomenon. Okay, so basically what happens in Pathology Phenomenon is you can detect it by testing the pathology test. So it refers to the development of new lesion at the site of eliciting the test. So if you see that when you inject this needle at an angle of around 30 degrees from the skin at a depth of around 1.5 to 2 millimeter with your bevel pointing downward into the dermis, okay, at the site of the prick, you will see an erythematous papule like this. Okay, you will see an erythematous papule of more than 2 millimeter at the prick site with a 20 to 22 gauge needle. Okay, now this test is called as a positive pathology test. Okay, you can also do it by injecting normal saline, 0.1 ml of normal saline at a depth of 5 millimeter. Positive pathology test is regarded as one of the minor criteria for the diagnosis of Behçet's disease by the International Study Group Diagnostic Criteria for Behçet's disease. So please remember, pathology test, you will see it in multiple neutrophilic dermatosis, but most consistently it has been associated with Behçet's disease. You may also see it in pyoderma gangrenosum and other neutrophilic conditions. Okay, so pathogenesis of pathology phenomenon. Why does this happen? So skin injury which is caused by the needle prick, it apparently triggers a cutaneous inflammatory response and creates a new papule or pustule that suggests that there is increased or aberrant release of cytokines from keratinocytes or other cells in the epidermis or dermis. The specificity of the pathology reaction is very high, especially in Behçet's disease. That is about 99%, especially when it is positive at 48 hours. So pathology test is positive in Behçet's disease. It is positive in pyoderma gangrenosum, rheumatoid arthritis, inflammatory bowel disease, sometimes in healthy individuals, and in Sweet syndrome, that is acute febrile neutrophilic dermatosis, it can be a rare phenomenon. Now, ulceronecrotic lesions are seen in Lucio Phenomenon, tuberculoid leprosy, indeterminate leprosy or histioid leprosy. Ulceronecrotic lesions are seen in which of these conditions? Anyone? MedPsycho, Yogesh, anyone? Humble Doctor says A. Chandni, Pankaj. Okay, Humble Doctor, you are right. So the correct answer here is Lucio Phenomenon. Okay. Now, Lucio leprosy. What is Lucio leprosy? It's also called as non-nodular lepromatous leprosy. Okay. Non-nodular lepromatous leprosy means there is diffuse infiltration of the skin, right? And this is also called as lepra bonita. This condition is seen in Mexico, Central America. Here you have diffuse infiltration of the skin, right? Because of the diffuse infiltration of the skin, the wrinkles are all ironed out. So the patient's skin appears taut and shiny, right? So that is why it is also called as lepra bonita, because it makes you look younger. So it's also called as beautiful leprosy, right? So lepra bonita means beautiful leprosy. Now what is Lucio phenomenon? Lucio phenomenon is a very peculiar type of reactional state which is seen in patients with Lucio leprosy. It has been characterized by classically patients who are undiagnosed, untreated, non-nodular diffuse form of leprosy. You see Lucio leprosy. In those people you see this phenomenon. So here you see necrotic irregular geometric ulcers which are characteristic of this reactional state. The evolution of lesions is very typical, progressing from erythematous ill-defined to plainful plaques to jagged skin ulcerations. The lesions are extensive, they are distributed over the legs, thighs and forearms. So this is what it looks like. The histopathology shows the colonization of the endothelial cells by the acid-fast bacilli. There is ischemic necrosis, necrotizing vasculitis of the small vessels of the superficial dermis, and endothelial proliferation of the medium-sized vessels of the mid-dermis with passive venous congestion and neutrophilic infiltration. Now what you need to remember is that Lucio phenomenon, it's a kind of a reaction occurring in Lucio leprosy, but it does not respond to steroids, it does not respond to thalidomide. Basically, because we see that there is so much colonization of endothelial cells by the acid-fast bacilli, it responds to multi-drug therapy. Okay, so you give WHO approved multi-drug therapy in these individuals, and that is found to be effective in the treatment of Lucio's phenomenon. Okay, now this will be our last question that we discuss for the day. We have 5 minutes. If you have any questions, any specific doubts, if you want me to discuss anything specifically, please let me know. Right? Now, all of the following are true about Reynolds disease except it's more common in females. There are positive anti-nuclear antibodies. The most common cause of Reynolds phenomenon is Reynolds phenomenon is Reynolds disease. It has a good prognosis. So what do you think, which is true except? So you have to tell me what's false. Anyone? They are asking you about Reynolds disease. Okay. The correct answer here is that it is more common in the males and not in the females. So basically, what is Reynolds phenomenon? It's a vasospastic disorder which is characterized by episodic changes in the blood flow in the cutaneous vasculature. So Reynolds phenomenon is something that you will see more in the colder seasons, and it is characterized by triphasic color change of pallor, cyanosis and hyperemia. In the first phase, there is intense vasospasm. So the digits, they turn pale to dead white because of the decreased blood flow. Then in the next phase, there is bluish black discoloration of the skin due to venous congestion and increased concentration of the deoxygenated blood in the peripheral circulation. And then on rewarming, there is rubor and erythema because of vasodilatation and accumulation of vasoactive dilator peptide-like substance P. So basically, the first two phases, that is the pallor and the deoxygenated blood blue color discoloration, is associated with intense pain because of cutaneous ischemia. While in the phase of rewarming, what happens is there is release of prostaglandins, and this third phase can cause reperfusion injury due to the production of reactive oxygen species. Now the causes of Reynolds phenomenon, they are multiple, but what is Reynolds disease? Reynolds disease is the primary idiopathic Reynolds phenomenon. It's called as Reynolds disease. Secondary are multiple, all the connective tissue conditions. Please also remember the drugs which cause Reynolds phenomenon. They include ergotamines, bromocriptine, clonidine, cyclosporin, bleomycin and vinyl chloride. Now, let's go to this last question. Splendor phenomenon is seen in Kaposi sarcoma, actinomycosis, sarcoidosis or systemic lupus erythematosus. Anyone? So MedPsycho is saying what is the correct answer in this, right? So all of the following are true except, right? So it is more common in females, positive anti-nuclear antibodies. Most common cause of Reynolds phenomenon is not Reynolds disease. It has a good prognosis is also true. So it is not more common in females, it is more common in the males. Okay, now let's discuss this. Splendor phenomenon is seen in come on, let's answer this. We have 1 minute to go. The correct answer here is actinomycosis. So Splendor phenomenon is a rare histopathological feature which is characterized by intensely eosinophilic material which is radiate star-like asteroid or club-shaped configurations around microorganisms, and this represents the deposition of antigen antibody complexes and debris from the host cells. So this is what you will see. You can see this. This is the Splendor phenomenon, which is a histopathological picture where you see intensely eosinophilic material around the microorganisms. Okay, these are the conditions in which you see the Splendor phenomenon. So you see it in actinomycosis, aspergillosis, botuliomycosis, eumycetomas, Myogenes granulomas, and non-infective conditions like allergic conjunctival granulomas and hypereosinophilic syndrome also shows this condition. Okay, so with that we end this session. Thank you very much everyone for actively participating, and hope to see you very soon in our next session. Please do subscribe to Unacademy, and when you do subscribe, please use the code MENTOR. Okay.